much. And I'd like to start by just saying a really big thank you to HIV Scotland for having us here today. This is a really important topic, and it's really great for NAT, the National AIDS Trust, to kind of be part, some of the work that we've done to be part of from the discussion today. And I'm going to talk a little bit about a guide that we produced that was actually published about 3 years ago now to start with, but also our colleague Joyce from the Scottish Care Inspectorate is also going to talk up just after me about some more recent work that we've done with them. And it's really great to work with HIV Scotland to kind of bring that up in today's discussion, so thank you. So I'm going to crack on just to talk a little bit about the background to why NAT did the work that we did. I think sometimes we reel off these stats and they do sound really quite impersonal. We've heard some of this already today, but 2 in 5 people living with HIV in the UK is over 50. Again, just to reiterate, we keep reeling off that stat. I think it's important to note that saying that someone is 50 plus does not mean that they are being classified as old. I think that what this shows, though, and what we've been able to see over time is that there is an increasing number of people kind of falling within this category. So I think in the actual guide, of which there are copies here, which was published in 2015, it actually says 1 in 4 for that stat. So you can see that the numbers, what we essentially have is an ageing population, and this is the term that we keep using all the time. The other thing that I think NAT was increasingly aware of, and that we've talked a little bit about today already, is how HIV disproportionately affects people from groups who experience other forms of marginalisation and prejudice. So something that I think has come up already is today is not just kind of stigma experienced around HIV status, but also stigma experienced potentially around sexuality or other things as well. And I think this is quite an important thing that kind of came up around the sort of the more holistic experience of someone living with HIV who might be accessing different types of care through the social care system. The other thing that we know is that people living with HIV are more likely to be living with other health conditions, and we often refer to these as comorbidities. And we actually know quite a lot more about this now because of the Positive Voices survey, and we know quite a lot about kind of some of the other health conditions that people living with HIV are disproportionately impacted by, and in particular, poor mental health is something that is talked about quite a lot. So this is something that I think is also a really important aspect of the experience of someone living with HIV that we need to consider. And HIV can bring additional worries and challenges that a lot of social care providers might not be aware of or think about on a day-to-day basis. So we knew that guidance already existed out there around things like sexuality and ethnicity and things like that, and how issues and topics and discussions around such things might be dealt with and should be dealt with by social care providers. But there wasn't anything specific about HIV. So we set out to address that and produce this guide. So the aims of the guide were to give care providers the information and advice that they need to ensure that they're delivering sensitive, supportive and caring services to people living with HIV. Something that we know there is both examples of good and poor practice of. It was also to ensure that commissioners understand the needs of people living with HIV who are requiring care, and to ensure that they commission services that then meet those needs. And it was also a tool for people living with HIV and their families or other people in their support network to ensure that they have access to the care that they need and that they have the right to access as well. So it's all about saying this is the type and the level of care that you should be able to expect. And it's to give people living with HIV a tool to take to care providers and say, these are the standards that you should be reaching for me. So this is a copy of the guide, the front cover on this slide here. It is available on our website in the publications section. And also there are hard copies in the room for you today. I did say this was published in 2015. And as we all know, there's been even further developments around, both data and science. So U equals U has become something that we have categorical evidence around now, which is why in the hard copies on the tables, there is a little updates slip, paper clipped inside with a few updates to kind of some of the things that we now know about the impact of treatment on transmission risk, as well as a few updates to stats and things. There is a hope that we can also update this guide for the online version as well quite soon, so that we'll have kind of all of that actually kind of printed within the official guide as well, which is online. But there is that in general, most of the stuff in this guide is absolutely still relevant, as relevant today as it was in 2015. And these are some of the sections that the guide covers. So we look at issues around confidentiality, HIV and infection control. We look at both medical care and psychological support, relationships and sexual health, diet, and then there's a section on protecting people's rights. So I'm going to talk a little bit more about some of these sections in a bit more detail. So confidentiality, this section is really around understanding why the need for confidentiality is so important and what we mean by confidentiality, but also addressing some of those kind of misguided beliefs that a lot of care providers sometimes have, people in the kind of in the health and care sector sometimes have, especially when they're not as familiar with working with HIV, and sometimes confusion and misguided sense of thinking that they need to share HIV status with more people, potentially to protect others, sort of slightly misguided views around their duty of care and things like that. So it's really to address those concerns head on. But also about actually sort of on the more proactive side of things, actually making suggestions around how not only do you reassure people around the confidentiality of their status, but also talking to them about what they do want shared and with who and when that is helpful. And I was really interested earlier on when Chris was talking, and he was talking not only about kind of breaches of confidentiality, but also issues that can arise when actually information about HIV status isn't usefully shared between care providers as well. So there is stuff within this guide about how you involve the person and their family if necessary, but their support networks and whoever they choose those people to be in the decision making around who knows and why they know. And I think that's really important. And I think that this particular quote that's up here is what we would, I suppose, see as a bit of a good practice example, where the person said, the person living with HIV is in control of their information. Apart from their care manager, nobody else has access to their file. The care manager has to get written consent from the person living with HIV before sharing this information. It is then up to each individual what information they choose to give to the care workers who come into their home. So this is about saying it's not a standard practice for anyone other than the person's care manager to have any awareness around their HIV status whatsoever. It's completely in the control of the person living with HIV, which is absolutely the way that it should be. However, unfortunately, there are examples where that's not how things have worked out. And this is part of the reason why we wanted to do this guide in the first place. And I think ultimately producing a guide like this doesn't solve all these problems overnight. So unfortunately, these are things that are not, that they're still part of people's experience. So one person said, things got off to a bad start as all the staff in the home were informed of my client's HIV status, although this was completely unnecessary. When his neighbours came to visit, the care assistant advised them not to let their child see him because he had HIV. So this is an incredibly difficult thing to read for a lot of us in the room who have just basic knowledge about HIV. And I think it just goes to show how quickly you can you can really start to collapse someone's kind of support network. So for the person who was accessing care through this service, for this to happen, it only takes kind of one breach of confidentiality to actually really kind of have a grave impact then on that person's life. And I think that's why we do need to make sure that actually some of these messages and things are understood before by care providers before they are ready, before they have patients who are accessing their services who are living with HIV. So it's about actually making sure that people are thinking, do we have the right practices in place now? If someone came into my service who was living with HIV, would I actually have the right things in place to make sure they were protected? And then the other one, they broke my confidentiality, telling the other residents that they shouldn't come and see me in my room because I had HIV. I was lucky my social worker helped me move to a new home where things are much better and they respect my confidentiality here. So the next section is around HIV and infection control. And this section is largely around reassuring and trying to make this point that there are not additional measures that need to be taken when a care provider is working with a person living with HIV. So it reminds people of how HIV is and is not transmitted, and underlines that there is no risk to health and social care staff. It also stresses the need for universal precautions and, critically, nothing more. And I think what's really useful is it does give good links and explains what those universal precautions are. And this is something that all people should expect. People should expect universal precautions to be used because universal precautions are in place to protect individuals receiving care from infections as well. It's not they're not in place to protect just to protect people from bloodborne viruses going one way. It's meant to be a mutually beneficial process. And then that critically, it also stresses that excessive precautions, so things like double gloving and things, can be seen as discriminatory and actually would be a breach of rights as well. And it's pulling out those examples. And here's a couple of kind of examples as well. When my client was discharged from hospital, he was too ill to go back to his flat and so was temporarily placed in a care home. He was made to feel very uncomfortable about the fact that he had HIV and was not treated the same way as the other residents. For example, they made him take the last bath of the day and use separate cutlery. And this is unfortunately something that we've heard quite a few times. And we still hear it as well in relation to hospital care sometimes. We actually intervened fairly recently on a case in England where a hospital trust was still putting people living with HIV to sort of the bottom of the list for surgeries, so that they were essentially the last person of the day to receive surgery, so that additional cleaning could apparently be done after surgery, which just seems completely ludicrous. And we were wondering what on earth they were doing between surgeries normally to mean that they felt that this was warranted. And these are the kinds of examples that we sometimes think have been left kind of 10, 15, 20 years in the past, but unfortunately it does still come up. And these are examples that we heard about kind of only about 3 years ago. And we have heard similar things being reported to us by people living with HIV since. So it's good to remind people that none of these kinds of practices are necessary and that, you know, someone's sort of basic care needs shouldn't be in any way compromised based on their HIV status. And this other person has sort of said, I felt that because of my HIV status, they were reluctant to help me in the shower and things. So this is really impacting on how the person feels, and it impacts on kind of the level of dignity that they are able to feel in terms of their access to care as well. So the next section is around medical care, and this is really about the importance of that relationship between the care provider and social care services and HIV care through the HIV clinic, and ensuring that that relationship works really well. If, for example, someone is in residential care, making sure that they are able to get to their appointments on time, making sure that there's really good communication links between the clinic and the residential home in order to ensure that any issues are raised and questions are raised and things like that. But also it's about this interaction with primary care as well, as we know that increasingly primary care has a really key role in the day-to-day management of health for a lot of people living with HIV, which has not always been the case. And there's a real kind of shift there that's been happening over the years. And this, though, does root back again to some of the discussion around confidentiality, because it's really important that the care provider knows actually what role primary care does play in this person's care. So not all people living with HIV will have told their GP about their HIV status. However, for other people, their GP plays a really, really key role. So actually those discussions about who in your care network actually is aware, who needs to be told first if you're looking for something, or if you have an inquiry regarding your care around your health. These are the kinds of things that are really important to kind of bottom out when someone first starts accessing a support service. Then there's something around needing to involve partners and not just immediate families about decisions about end-of-life care. So there is some stuff about end-of-life care in this guide. And I think that's something that is really, I haven't gone into too much detail here, but it is really important to kind of consider. And I think the reason why we've sort of said this about needing to involve partners and not just immediate family is because of some of these things that have come up, particularly for gay men who are living with HIV, who have experienced prejudices or have experienced barriers to their partners actually being part of the decision-making process around their care, and in particular then around end-of-life care. And it's something that I think is we felt was really important to address, because it was something that was kept coming up from people when talking to us. So again, it's all about these intersecting issues that were mentioned by both James and Chris earlier on in their presentations that we've tried to kind of address in this guide a little bit. So yeah. So a little bit on psychological support, and I I'm not sure psychological support is necessarily the best name for this section, because it's not just about kind of, I suppose, what we would consider, it's not necessarily about clinical psychological support as much as it is also about kind of I suppose, the non-medical kind of needs of someone living with HIV. We talked a lot today about loneliness and isolation and the impact of loneliness and isolation. That's something that impacts on older people disproportionately, but also we know impacts on people living with HIV disproportionately. And some of this might be very context-based and very place-based as well. So if someone is living in quite a rural setting and maybe doesn't have the same access to peer support as someone who's living in a city, which is something that has been talked about today, what does that mean for them? And actually, how can their social care provider actually think about ways around that and ways of getting them the support that they need? But I mean, some of the basic things that we address kind of in the guide is about making care providers aware that these support services exist and that there are such things as HIV specialist organisations that might be able to support with things and might be able to provide that kind of peer support link. And just basic things like making sure that someone actually has the option to be able to attend a support group of an evening or something, should they wish to. And that being actually potentially quite an important thing for that person in relation to their overall well-being and how they feel in their life and things. So that's what we're getting at really in this section of the report. The next bit around relationships and sexual health is again around really stressing the fact that people living with HIV have as much as a right to develop relationships and to develop sexual relationships as anyone else. And that this shouldn't be setting off alarm bells in care providers' minds every time they think, oh, I've got a person living with HIV and I think they're having sex. It's probably really none of your business, you know, and it's sort of about sort of thing, you know, and I think that kind of again, understanding how HIV is and isn't transmitted, and also doing what you would do for any other adult that you respect as a person, making sure that they have access to sexual health advice and support and services like anybody else, but you don't have a special duty of care towards people that person is having sex with, and I think it's about sort of discouraging this sort of paternalistic kind of approach towards these relationships. So this is really about, and it leads on really nicely to the next session around protecting people's rights as well, about thinking about actually a person living with HIV has as much of a right to embrace relationships and sexual relationships and to enjoy a healthy sex life should they wish to, as much as anybody else. And then, of course, there is protecting people's rights. And I think it's one thing that we thought was really important to make clear within this guide is actually how the law applies to HIV. So making it very clear that HIV is classed under the Equality Act as a disability from the point of diagnosis. Now, this does not mean that every person living with HIV considers themselves to have a disability. But what it does mean is that under the law, they are protected as though they do. So it is not legal to discriminate against someone living with HIV based on their status under the law. And in doing so, actually, not only are you potentially you're potentially having an impact on their dignity and their well-being and their experience and their ability to live well with HIV, you are also breaking the law as well. We also refer here to the Human Rights Act and important components of the Human Rights Act that apply to the lives of people living with HIV and that might be useful as well for people living with HIV and their networks and care providers or people trying to get care in place for someone living with HIV to actually say, okay, these are the bits of the law that we want to rely on in order to prove that this person has the right to access this. And I think what's really vital here is that people understand that they should never be refused a service and activity just because they have HIV, and there are no examples where that would be okay. They shouldn't be charged more, and they should be protected from harassment as well. And harassment is something which is sometimes not dealt with, and things like breaches of confidentiality things are often really, they fall under this harassment kind of what we often refer to as harassment, and often it's seen that that's not something that someone has recourse to that someone can deal with, because it might not feel like direct discrimination because they're not being refused a service or something like that, but actually there are protections under the law around this. I just want to talk briefly about some other training materials that we've got as well, that were kind of produced around the same sort of time as this, that I think are quite key and might be important for me to flag here. So we have essentially a PowerPoint presentation, which is a sort of really basic training tool for care providers that is available on our website in the publications section as well. And within that, it covers a lot of stuff that's in the guide, but it also has a few more slightly detailed case studies, which will, with sort of key questions in there to help care providers to think a little bit about what they should and shouldn't have done in certain situations. So this is an example, someone called Rita, and these case studies are actually real examples as well. Some of them are a conflation of a few different ones together. I'm going to try and read this, and it's very small, sorry. But this is an example of someone who, again, was given separate cutlery to other people and things like that. And then it's asking key questions of care providers to think about in the training setting where it's actually safe to maybe do so, and think about why that happened, what could you do to counter it and things like that. So actually asking people, what went wrong here? What should they have done? How could we do things differently? How would you rectify this? So these are the kinds of things that we have available online, and there's a few more examples and case studies within that training. We also have available on our website an e-learning resource as well, which has as well at the end of it a little assessment that you can do. You can't quite see it on the screen here, but there's some tabs along the bottom, and there's different sections, and you can go through that resource and read a little bit more. It's kind of done in Q&A format, and then there's a little quiz at the end that you can do. So that's just another thing that we have available. And I'm going to stop there. Thank you.
Kat, thank you very much. There was a huge amount covered there. There was just one thing I wanted to pick up on to get a clearer understanding of is when a paternalistic approach can lead to stigma and discrimination. Could you maybe unpack that for me a little bit more, and maybe some examples and how it relates to other areas as well?
Right, yes, I can try to, and I think it might be something that other people on the floor might have examples of as well. I think that the clearest example is often kind of if a person living with HIV is in sort of sexual relationships or something, we actually get quite a lot of queries at NAT. So we'll get actual care providers phoning us concerned essentially about whether or not they should intervene. So should they be, for example, telling this person's sexual partner that they're living with HIV? And I think what we would sort of stress in those situations is that actually these are conversations that actually the HIV clinician is very used to having with individuals. Often also it's based on a misunderstanding around the science of HIV. So for example, we explain, well, actually this person that's accessing your care service, you know that they're on treatment, so the chances are they actually cannot pass the virus on, which is often very reassuring, and they'll go, oh, okay, I don't need to worry then. But I think it's about kind of understanding where their duty of care lies, and sort of we often I think even amongst sort of some of those providers who have the best intentions, once you start bringing in discussion around sexual relationships and things like that, some of the things that some of the beliefs that they have around confidentiality and things like that start to break down because they suddenly feel like they need to intervene in some way. So that's what I meant by that. Does that answer your question?
Yeah, it does. Is this something that resonates with people here?
We talk about, sexual health and sexual identity and all sorts, but in my personal experience, I'm a nurse as well, have some experience of care homes, not much, but I do have enough. Look, if you're in a long-term care facility, let's say you've been in a stable relationship for 50 years and suddenly you need to go into a care home. The very thought sometimes I think of people actually having sex at that age is quite it's a bit, people laugh behind their hands, a bit kind of, ooh, somebody's having sex. So unless you can move forward from just the fact that someone can have sex and be in their older years, that's what you need to cross first before you can then talk about sexual health. And it's something I repeat in other things that I've done as well. If you don't talk about sex, how can you talk about sexual health? So to enable us to talk about sexual health and HIV, surely we need to get over this kind of like behind the hand kind of tittery stuff, carry on humour about it in older people. So that's definitely one bridge you need to cross in the first place, I think. The other thing is, I know that the good work the HIV Scotland's done, yourself and other organisations when it comes to care homes. Sorry, I've just gone off track here. Sorry, I forgot what I was going to say next. But it's something that we definitely need to look at is how do we talk about sex in care homes? And when you're a nurse, I've remembered what I was going to say. Nurses used to at one time deal with activities of daily living. So that's carers and nurses, and we're all nurses at the end of the day. And involved in that, an initial assessment was something about, do you still have sex? Because activities of daily living includes your sex life. That's not included in anybody's activities of daily living now, because I would find it very difficult if I admitted a patient to say, at age 5, are you still having sex? Would you like any sexual health advice? So until we start to include that and remove the kind of Victorian attitude we have towards sex, how are we going to move forward to talk about sexual health, and particularly in care environments? And if I would add, there's a really good piece of work on the National HIV Nurses Association website, telling people how they can talk about HIV in the clinical situation. I don't know if that's been looked at or if it's been picked up by anybody else, but I think it'd be quite useful to look at from a training point of view. Also, can I ask, Kat, just on the training package, the e-learning module, it'd be really useful because we're now trying to regulate care healthcare assistants or care workers or whatever we call them in care homes, to make sure they've got kind of professional development. That would be extremely useful for the carers. Is there a time, do you say how many hours it would take to complete the e-learning module? Because that's vital to the training and to add to their CPD. So just some comments and thoughts, really.
Yeah.
Thanks.
Do you want me to? Yeah. So yeah, I completely agree with you. I think the point around kind of thinking the point that I was making around this sort of paternalistic approach sometimes doesn't only apply to HIV, and I think there is a broader issue there around and this is where again it's an issue that intersects in so many ways with different ones, and I think it becomes. I think it's also about respecting people. It's about respecting LGBT relationships as well, and things like that. And just generally how we talk about sex amongst older people, other people who might be accessing care. So it's not only an issue affecting people living with HIV, but this is one example of where it can come to the fore. And in terms of the e-learning module, it's not. It really does depend on how long someone wants to spend on it, basically. But I would say it's a 1 to 2 hours kind of thing.
Can I just ask a quick question? I know that HIV and dementia are quite often related. A lot of what you've talked about on confidentiality and respecting rights and so forth are, they're challenging when somebody's got dementia. And have you got any special category to deal with that specific area?
So yeah, dementia is I didn't mention it in this, but that link between HIV and dementia is picked up within the guide, and it is referred to briefly. I do think that's something we could develop a little bit further, though, that particular issue. But yes, dementia and HIV-related dementia are both things that are picked up in the guide in a little bit more detail.
Thank you. I was just going to follow up on the question of CPD for carers. So at the moment, we're doing a project in Grampian, northeast of Scotland, around improving the experience of care for older people going into care homes. And one of the things that we're looking at doing is develop some e-learning resources for carers. We know that they don't have the time, so we're thinking about making them into modules, so 20 minutes, 10 minutes, so that they can go back, they can do them in their own time, because I think 2 hours would probably be too long. They wouldn't have 2 hours.
Yeah.
Sometimes the care homes don't even have computers, so we're trying to make it as easy as possible. We're going to use all different ways of getting to them. Hopefully we would get them to do some of this at induction, some of it as continuous CPD and things like that. But we're still in the process of doing that just now.
Can I add? We're doing this work on the back of a survey that we did with care home staff. We sent out a survey to all the care homes in Grampian and we got quite a good response. About 200 people responded. And it was about their knowledge and their attitudes towards people with living with HIV in the context of care homes. And just to touch on just a few things, there's obviously a great need for this information that you've got in here to be disseminated. Because, for example, over 80% of staff thought that if they had a resident living with HIV, then everybody in the care home, no, all the staff in the care home should be informed of their status.
Yeah.
And also about half of them thought that they should use extra protective gear when they were looking after them.
Yeah, thank you. That's really helpful. I think it really demonstrates why it's really important to have this information made available, not sort of after the point at which a care home is made aware that they have someone maybe living within the home who is living with HIV. Because as I think one of the examples showed that I was talking about earlier, all it takes, as soon as that's happened, as soon as all of the staff have been made aware, it's out there then. And that person's experience is going to be deeply impacted by that. And they may not even be able to feel that they can remain in that care home. And we have had examples where people have felt that they've needed to change kind of care providers for reasons like that. And actually in some areas there might not be that many other options, and it's obviously really difficult to get access to certain forms of social care and things, so those options might not be available. So it is really important to get this right and to make sure that awareness is there before it gets to that point, and to be thinking about the needs of, I suppose, an increasing population of people who may need to access social care in the future, not only those who are accessing it now.
Quite a lot about the training needs that
I'm sure, yeah. Great, thank you.
Thank you, and thank you again, Cass. A really useful exchange.